introduce yourself.
Yeah, I'm Jim Lederer. I'm new to the Berkshire Health System. I joined in January of this year. I'm the Chief Medical Officer, Chief Quality Officer, and I have the privilege of, fortunately, being an infectious disease doc, and I think this kind of event is something I've been doing since the fall of the Twin Towers and the smallpox risk and threat of bioterrorism. So it seems like every few years there's another potential pandemic or real pandemic.
Yeah. Now this one is definitely a real one.
This is a real one.
Yeah, and for us, there were always preparations for like MERS or SARS. This one is the first one in my memory that has really affected our state and our region to this degree.
Absolutely.
Yeah.
No, I think, even H1N1, when it first occurred, it was certainly something that, we had prior knowledge of how flu worked, and we had expectations. We really had no knowledge over what to expect with this, other than the SARS or the MERS experience, and those weren't good.
No, and it seemed like, at least in the beginning, BMC was certainly aware of it. I tried to find the date where I had gone into the hospital for, there was a medical procedure that we went in for, and all the desks had signs saying, if you've been to China, if you've been in these areas, please make sure you're telling people. So it seemed like, at least BMC was certainly trying to make sure that they were catching anything in the beginning.
Oh yeah, no, I think prior to my arrival, the infection prevention department and the infectious disease specialists on staff, were cued into what was happening, and we're actually looking at our preparedness, from some of their prior work and from what we might possibly need. And so they were already looking at things like PPE availability and trying to gain more knowledge from either the World Health Organization or the CDC. So I think when February 29th rolled around and our first patient arrived, I think we were ready, if you can be ready.
Right. So what for the patients, there's been about 60 patients have come through the hospital. I'm just going by some of the statistics that the hospital has been posting on their COVID page. That 21, around 21 are in there now, about 40 have been discharged.
Correct.
So what kind of symptoms were you seeing as these patients were coming in? Was it mostly respiratory distress?
It is, and again, we get a stilted view of things because we see people at the extreme end of the spectrum. And so in order to get admitted, you're going to have significant respiratory compromise, fever, chest congestion, shortness of breath, maybe chest pain. I didn't get the sense that many of these patients had exacerbations of underlying conditions, that this was predominantly a pneumonia presentation. And that's what we would expect, as different from a lot of the rest of the community, some of whom are using our drive-through testing and have minimal symptoms, but they all have symptoms. They're just not anywhere near the degree of patients admitted.
And I'm assuming that the hospital has a separate facility set up for the patients from there. Did you use, hospitals keep changing over how they designate things. So I'm assuming it would be like the ICU area at this point, intensive care? Well,
I'd say probably 20–25% of our patient volume total has been in ICU, and the rest have been on the general medical ward. So we have tried to cohort either known positives or suspect positives together, really to make the PPE and the care more amenable to the staff. And then for other parts of the hospital, people who still fall and break a leg and need a surgical repair, that's a different ward, a different unit, where again, for the safety of the patient and the other patients, we try and cohort non-COVID patients together.
Right, right. And do you have, I mean, obviously, personal protective gear was incredibly difficult to access, and it's still hard in some areas. Does BMC have enough at this point?
Well, you know, I can answer the question by saying we never have enough. You know, and I think this has pointed out that problem to us, is that, you know, you don't know what the surge will look like. You don't know how many patients you'll have in the next week. You don't know, you know, to what degree, you know, they'll need intensive care unit care versus general medical care, the number of people going in and out of the room, the number of people who need PPE to do that. You know, we are as well positioned, I think, as we could be, and some of that in large part due to early recognition and early work by our supply chain and others to just get out ahead of this. But if what we are seeing is, instead of a surge, more of just a flat persistence of patient volume, and this goes on for months, unless the supply chain ramps up, you know, we're going to find ourselves wishing we had more.
Yeah. So what do you think from what you've been able to see at this point in your experience, obviously if there's going to be a surge, a lot of it's going to be in the eastern part of the state. Are you feeling there's going to be more patients coming in over the next week?
Well, that's what the Department of Public Health models, and
Yeah.
that's what they think. But I think all those models are predicated on, you know, existing models developed in Wuhan, China, and other places, and you know, the Berkshires is just not the population density of Wuhan, China, much, you know, nor Boston, nor Springfield for that matter. So, you know, we are a big county, and we're widely dispersed. You know, even our most concentrated is an apartment complex or two here and there. And so we really just don't have the population density. I think early on, with the first cases, you know, we got the word out about social distancing. We got the word out about, you know, what you can do to protect yourself. Obviously, our local health department and mayor, you know, rapidly got on board and started helping with kind of public advisories and public service announcements on what people could do. And then ultimately the governor followed suit, you know, with his declaration of an emergency. So I think that, you know, while the eastern part of the state is going to suffer from true population density problems, and, you know, just the number of people they have, you know, per downtown city block versus what we have here, I think that, you know, we are seeing a flattening. I hope it continues. Our main concern about a surge now is recognizing that this seems to be getting into high density living situations, congregate care situations like skilled nursing facilities and nursing home and assisted living. And I think that's where the challenge will come.
Yeah, it's very difficult to separate these types of facilities, because you can test all you want inside the facility and make sure they're safe, but there's still staff coming in and out. There's deliveries coming in and out. So I know that makes it very difficult. So obviously Berkshire Medical Center works with Berkshire Healthcare, which runs a number of nursing homes. Are you kept updated on how well they're able to contain within these facilities?
Oh yeah, we have an incident command call every day at 11 o'clock, kind of a situational update, and that includes the you know, Berkshire faculty practices, all the clinics. It includes the nursing homes. You know, it includes linkages to EMS, and so, you know, we have a good process, and I think that's, you know, helped us to address concerns and needs. And likewise, we then call the state and have a call every day at 1 o'clock. And so we're able to talk through maybe some resource needs and testing kit needs, or, you know, obviously personal protective equipment. You know, we're always kind of pulsing where the state is and what they have available to them, or what they know about the supply chain. And, you know, we can twist the arms of our manufacturers a little bit more. So, you know, either local at our 11 o'clock call or regional through the Commonwealth at our 1 o'clock call. We feel like we have good connections across the state.
The governor this morning mentioned that there would be, they were planning a recovery center in Great Barrington. Would the hospital, the healthcare system be involved in that at all?
I think obviously because this is our community, and anyone that would be in that center, would ultimately need to, have care from us.
Right.
I think, we'll certainly be, I don't know that we will be manning it or administering, the office functions of it, but obviously, if something like that were to take place, we'd be intimately involved and would need to collaborate closely.
So another thing I wanted to ask about, because a lot of people are concerned about it, is obviously wearing masks, because first we were told don't wear masks, and then they were being told do wear a mask, but then it's what kind of mask are you wearing, and is it really helping you? I mean, could you clarify a little bit about that?
Well, without sounding like I've been through this many, many times,
Yeah.
and it frustrates me today as much as it ever did, it's, I think the CDC, in an abundance of caution and to prevent harm, oftentimes starts at a very stringent set of policies and care algorithms, and then over time, either because of true pragmatic resource, investigations and determinations, or because emerging data comes out, they tend to loosen up. So, SARS was an airborne isolation emerging
Right.
disease, and then ultimately it turned into just a normal coronavirus with masking for surgical masks and droplet protection. And so, we're in that mixed world here. In a perfect world, I think we would love to all have N95s, but we don't have that number. So, we've masked our respiratory patients and have asked them to, to pull their masks up when we enter the room and wear surgical masks if need be. Or, on those high-risk units, true COVID positive patients, then N95s are used. Eye protection, gown and gloves in certain situations. So we do what we can, and then the real question is, how long can we continue to do that with the current patient volume and the in-house census of, right now it's about 20 known positives, 25 known positives, and 7 or 8 pendings. So
Right.
that's 33 patients that will use some element of personal protective equipment day in and day out by everyone who enters that patient's room.
Right.
And our normal use of PPE, of the N95 masks, this is why it's so frustrating to hear some of our national leaders, suggest that people are selling these out the back door. That's not what's happening at all. Normally we use a box of 20 N95s a week. And so that's 80 for the month. That's all we have ever used. We need them every now and then for tuberculosis patients, sometimes for chickenpox patients, but not much beyond that. And so, that 80 masks would be used by potentially 2 or 3 patients in just a matter of a couple days. And if we have 30 some patients and we have multiple caregivers, and you consider an ICU stay versus a general medical stay, then there's probably even more caregivers. So, that 80 quickly turns into the need for thousands. And yet we only are allowed to purchase what we historically have purchased in the past. And so the just-in-time manufacturing, no manufacturer wants to have huge warehouses of masks go unsold.
Right.
That's not good for business. So if I bought 80 last month, I'm allowed to get 80 this month. So in February, I bought 80, and then in March, I needed 5,000. And
That's yeah. Yeah, I think especially when people hear, oh, well, we got 1 million masks, the Patriots brought in 1 million masks, that should be enough. But when you start talking about numbers like that, it becomes apparent that you can go through them pretty quickly.
Oh yeah, and Berkshire Medical Center is, by all accounts, it's a medium-sized to small hospital. you consider some of the inner city Boston hospitals with 500 and 700 and 900 beds, you can see quickly that a surge for them is a stress on the staff, it's a stress on the resources, and they're in the same boat that everyone else is across the country. The manufacturers have to gear up, they have to start new shifts, they have to have more production time, they need to get it out, and then who do you give it to first?
Yeah, who's the first one there with the check, right?
Right. And we are to some degree
to your hospital.
Yeah, I mean, we're competing against other states and other hospitals for the same limited resource.
It must make it difficult.
It's frustrating.
Well, I'm glad you talked about that too, because I know that I've read a lot of things that there's always, and I don't want to get into like a lot of conspiracy theories, but this idea that, you can't see this battle that's being waged, and because the streets are empty. Well, because people are in the hospital, and you're not attacking it with flamethrowers and swords. It's a quiet battle that's going on a constant basis. Can you talk about how sort of the time that for anybody who, and I've been in ICU, and there's a lot of on-hand care that goes with somebody who's in ICU. There's a lot of technology involved. Can you speak to a little bit about sort of the man hours that go into taking care of somebody who's on a ventilator?
Oh, it's immense, and put that into the big mix. It's immense across the hospital, because just the mere act of gowning and gloving and masking and putting on a face shield, there's more time, and going in the room, and then wanting to be cognizant and effective at your hand hygiene, making sure that you don't transmit to the next patient. There's just a lot that are that weigh heavily on the shoulders of the caregivers who are at the bedside, and they're long shifts. It's not like it's just one single patient. Just having a single TB patient in the hospital is time consuming for that nurse caring for that patient, and now we're multiplying that by 35. And so it's just a lot of work, and unfortunately there's not a magic bullet from a pharmaceutical perspective or a medication, so that after 24 to 48 hours of getting the proper antibiotic for a bacterial pneumonia, the patient starts improving and feeling better, and you can breathe a little sigh of relief, and the patient's feeling stronger, and from a nurse's perspective or a doctor's perspective, that's a good sign. And here it's just supportive care and tincture of time. There are drugs that are being tried, but none of them really have the proof of the peer review literature to say this works and this doesn't.
Yeah, I think there are concerns that there may not be a vaccine for this particular coronavirus, because now they say they're finding people are reinfecting.
Well, yeah, it's hard to know if they're getting reinfected or they just never cleared their viral shedding. And so, we've seen a couple patients who were negative, positive, negative, positive. I mean, it's just, and you don't know what to make of that. It's not likely reinfection in the short term, but, we anticipate that surviving a coronavirus infection, the COVID-19 infection, at least for the short term, there should be immunity. I mean, that's why you got better, was your body reacted against the virus, developed antibodies, developed recognition, took it out of play, and you then were able to heal and get better. But will that immunity last for 6 months? Will it last for 9 months or a year? Or will the virus in the next 18 months undergo a minor antigenic variation, drift we call it, and look a little different and is able to evade the host defenses? And so you thought you had been immune to that strain, and you were to that strain, but it mutated slightly, and now it's a new strain.
Okay, so we're almost done with our time here. So can you just tell our viewers what is the most important thing that they should be doing right now?
Well, right now, I'm going to change my tone a little bit. I think from the COVID virus perspective, if you think you have it and if you think you need help, then come to the emergency room, come to our urgent care centers. That's what we're here for. We are wearing our protective equipment. We will place a mask on you and your loved ones when they come into our facilities, so they're protected, and that's what we're here for. But more importantly, there's an awful lot of people out there in the community with heart disease and asthma and chronic bronchitis and COPD and diabetes and histories of strokes or TIAs. If you're at home experiencing any worsening of your normal known medical conditions, that's also what we're here for. We've seen some deaths in the community that are very upsetting to us because they were young patients and they were preventable. And our fear is that either people they were concerned about coming here because of this being where the COVID virus is. But if you have medical conditions, there's not going to be an emergency room physician at your doorstep. And so we've recognized that, and by our masking and by our offering masks to both you and your support people who come with you to the emergency department or into our urgent care, even into our physician practices, we're hoping that that can give some comfort and ability to re-engage if you need to, because that's, healthcare is what we do. We're here for our community, and we're here for your needs. And staying home sometimes might seem like the safest to you, and it's certainly listening to what the governor says. But sometimes, you need to recognize when it's beyond something you can manage on your own, and come in and get help. And if there's a concern, let us help answer that concern and get you back to, a healthy status.
All right. All right. Thank you very much for speaking with us.
I'm always happy to.
Okay. All right. Thanks.
Thanks.